What is up, everyone? Thank you for joining us for another episode of Kinetic Innovators Podcast. And with me in the studio today, I have the Chief Operating Officer of a company here from Atlanta called HSBlox. Lynn Carroll is joining me in the studio today. I've been working on doing some projects with them, actually, that haven't happened yet, but they're coming down the tracks. It's part of how we got to know Lynn and the capabilities that HSBlox brings. So thanks for stepping into the studio with us and talking a little bit about the company.
Hi, CW. It's always good to see you. So I'm looking forward to the discussion today.
If you check out your background, obviously you've been associated with healthcare in some form or fashion pretty much all your career. You want to share a little bit with listeners about some of that history and what brought you to this place?
Sure, I'll tell you a little bit. I got my start in the healthcare industry, actually processing claims when I was in high school, and that led into a senior project when I was at the University of Illinois to put in a budgeting system for a provider-sponsored plan. That ultimately led to me running the finance division of that insurance company for about 12 years. And during that time, the HIPAA transactions were finalized, and we started to use a lot more standardized transactions to move things like money underneath different types of program and contract designs. And of course, this is taking me back several years. I mean, this is 35 years ago. But as the push started to go in the direction of more value-based types of programs, we saw an opportunity to put together a platform that would be able to automate a significant amount of that work. Most of that work today even is still fairly manual and has a lot of different spreadsheet jockeying going on. But with our platform, our goal was to be able to help the industry move quicker and with more efficiency into these types of alternative payment models.
So let's talk a little bit about HSBlox, because you have technology platform and solutions around that kind of tackle a number of different facets of administering a value-based care entity. But if you can just give a quick intro to the company. When did it come around, and what inspired its creation?
Sure. So my background, as you mentioned, has been in the industry for a number of years, but recently in the late 2010 era, both myself and my business partner, Rahul Sharma, had different exits in the industry. He had one that was more related to the financial side, and then I had one that was truly value-based payments side of the equation. And we decided that we would put together a company that would focus on two different aspects of the value-based continuum. One, the need to have prospective bundling going on. So a lot of the traditional CMMI programs and other episodic and bundled programs were more retrospective in nature. But we saw a demand, particularly in the large self-funded employer space, to move to more prospective bundles. That was one impetus. And then the other impetus was just the proliferation of alternative payment constructs, certainly from CMS, and then with some of the larger commercial players, we saw an opportunity to create an administrative platform for moving funds, doing monthly, quarterly, and annual reconciliations, quality reporting, and other metrics germane to determining success of these programs.
So you think, man, we're going to be an ACO. We're going to make all kinds of shared savings and have risk and all that kind of stuff. Cool. We got our contract put together and here we go. That's when the hard stuff actually begins. You got to actually be able to track all kinds of details. So let's dig into that a little bit. So, when a value-based care entity or health plans come to you, I mean, what are they looking to have HSBlox facilitate? Because there's a lot of data that you got to track, from the contract terms to who's part of the plan to any specifics related to this group or that group in terms of the fees that they get paid out for various services.
Sure. Yeah. I mean, it is quite complex. It seems simple. Most folks will say, hey, value-based care makes good sense, why isn't it taking off at light speed or warp speed? And one of the challenges is the actual administrative componentry. So when you think about understanding what the population is that's going to be attributed to a given risk bearer, and understanding not only that population, but then trying to forecast and understand what financially it could mean. You have to stratify that population. You have to model the contract in terms of what is in and out of the division of financial responsibility on both sides. So whoever's paying for the services under a given program design and who is rendering those, there will be division of who's ultimately financially responsible for different parts of the program. That can be complex, which is one of the reasons we have a contract modeling tool on the platform to take a look at the assigned population, look at some historical data, make some projections about risk characteristics within that population, and generate ultimately pro formas. Those pro formas then on the system are very helpful to then operationalize once you have agreement or you have a particular program design in mind, to then track both financially and from a metric standpoint against the program and its progress.
So when you talk about the panel data or patient related data, are we talking about what diagnosis codes are present, that type of historical documented?
Yeah, so we're
risk scored,
Yep.
HCCs, that kind of thing being
We
recorded?
are certainly underneath the Medicare programs, and then there are also proprietary scoring methods that are used by a lot of organizations to think about, from a business rule standpoint, how they want to stratify the population and what they're willing to take risk on. So a lot of that ends up being carved in or carved out of a given program design. And that's where, the splitting hairs aspect of these types of programs can be cumbersome unless you have a very good platform for doing so. We've learned a little bit each time we've done one of these platforms. This is actually the fourth reimbursement related platform that we have done. And each time we've carried along a little more tribal knowledge with what it takes to be able to not only administer the programs, but distribute funds, look at the shared savings components, rebaseline different program designs for coming years. We've actually seen a lot of work happening in specialty carve-out scenarios on the commercial side, particularly as we've worked in a lot of the direct-to-employer space as well. So it can be very cumbersome to administer not only one, but multiple programs. And so one of the premises of our platform is that a given provider should be able to participate on this platform as part of one program or multiple, across multiple sources of funds, across multiple locations, where some locations the provider may not participate, but others the provider might. And a big tenet of the platform is trying to achieve that alignment between primary care, specialty care, and ultimately the hospital. Because capitation has been well known at the primary care level for years, but where a lot of the spending is in that specialty component, and a lot of the quality metrics at the hospital side are driven by specialists. So the premise of the platform is get that alignment and create the types of programs that can be tracked and can be successful.
Where is the data flowing to you from? Who's the primary source, if you will, of what's going on with the members of a given panel of people?
Yeah, so typically in some of the CMS programs, we're processing files that are directly delivered from CMS. There'll be some augmentative files that will also come in, usually from our clients. That tends to be more on the provider side of things. On the more commercial and direct to employer side, we're typically taking things directly from payer organizations, either commercial payers or TPAs on behalf of employers. We have an onboarding mechanism that sort of stratifies things between where's the data coming from, who's taking action on it, and then who's participating in the program design.
So do you maintain, I guess, some level of just connectivity with a given health plan. Once you've worked with them, I guess once, now you've got an API or some kind of other digital connection to their data system, such that if some other group that's also contracted with them participates in some value-based care measure, you can just...
We do, yeah. So a lot of our connections for some of the heavier lifts or the larger amounts of data are direct, but we will also connect through health insurance information providers, HISPs, that are out there. These are the old ENAC certified companies that will do some data exchange coordination. So those will be some of the other ones that we will connect to.
Pretty interesting that whenever you're just launching out and get set up with your platform, that you can actually kind of have some measure of projection. I'm sure, obviously, extremely useful for setting initial benchmarks and just targeting groups of patients. From what I understand, looking at the website, part of what you also facilitate is you can facilitate the movement of money. You touched on that here, but then also some level of communications management as well.
We do. And so one of the things that we have is a communications engine. It's a tool that's put together. It has a web component and then also has a mobile component for things like surveys and feedback loops, not only from patients, but from caregivers under certain programs where there will be a need to, achieve a benchmark based upon either some form of engagement or other outcome-based measure that might be patient reported, it might be provider reported, or it might be from the chart. So we do some digitization with that tool as well. So if it is, for example, unstructured data in text, we will process that data, give it some context using UMLS to tag it so it has relevance for analytics, and bring that in. Another part of sort of that same tool is that we also bring in transparency data from the transparency regs. So when you want to benchmark a given program against what the rates are in the market, this is particularly relevant when you get into some direct-to-employer types of contracts. That information can be used inside our contract modeling tool.
When you're looking at the payment side of things and the movement of money according to contract terms and so forth, talk about that a little bit to help the listeners understand, where this key component is going to be moving their funds around and how they can tell, is it getting to the right place? What are the balances doing? Those all that type of data tracking. How are we doing? I guess, and it's in real time.
Yeah, so a couple of things about it. One is that our pedigree has always been in moving money under these types of programs. So in these programs, we will typically be integrated with a disbursement bank for whoever needs to move the monies. We will also validate enrollment of payees onto our system. So use third-party tools to not only validate that the accounts are good, but also who owns those accounts before they become activated on the platform. And the reconciliation components, we provide different reporting mechanisms that are available to both the payer of the transaction and the provider that show when the money was dispersed. A lot of those capabilities come in pretty useful to the payer side with regard to not only understanding different transactions and modalities that are going out, but also enable them to think about cash planning, and usually can allocate different approaches to retrieve overages. For example, if CMS gives them a wrong file and monies go out that shouldn't, then we have ability to track and recoup those monies on behalf of them, which is a nice tool for folks as well.
And I would imagine on some level, does your platform contribute data if I'm getting audited in some form or fashion as my value-based care entity that
Sure.
would contribute value there?
Yep, we're also SOC 2 Type 2 plus HITRUST audited organization, so we have a lot of tracking mechanisms on our platform. Usually we expose a good portion of those through the UI so that audits can be conducted very easily and exports can be made of different user transactions, who did what transaction at what point in time and what was changed from a historical standpoint. And then typically at the end of a quarter, end of a year, we will also be exporting information to the data lakes of our customers for different tax related purposes, obviously underneath the payment side of things.
So who is the typical end user? What's their role, or that is typically going in and actually, clicking around and doing reports and tracking what's happening in real time? What's that person usually look like?
So it's usually a combination of really kind of three areas. One is operational folks who are monitoring programs on an ongoing basis to look at different outcomes, not only financially, but also on the reporting side. So those folks will come from two areas, operations and from medical management typically, and then, or care management. And then finance is always in the system, looking at the different reconciliations, movement of funds, forecasting measures, and ensuring that the reports that need to go out to the constituents who participate in these programs are in fact going out monthly, quarterly, annually to do the reconciliation pieces.
And for the new user that's just coming online, they just find HSBlox, are they coming from self-funded health plans? Maybe they've been trying to keep track of their stuff on elegant spreadsheets, or maybe some other platform out there that's trying to do this. But what's that new user, that's coming to license the platform look like?
Yeah, so it's a good question. Typically, if you think about a statistical curve, the far left of the curve would be more traditional payer organizations who are consolidating different types of alternative payment programs, or maybe they're trying to streamline those or further automate them. In the middle is what we would call aggregator organizations. And these would be value-based types of networks that are bringing value networks to self-funded employers, usually larger ones that have footprints in several regional areas. And then ACOs fall into that class, as well as IPAs and other integrated delivery types of networks. And then on the far right of that curve would be traditional, just pure payer organizations. A lot of those would use a lot of our tools for modeling capabilities to understand a proposed contract or to put together a direct contract of their own based upon pushing data against different parameters that they're thinking about from a carve-in, carve-out scenario. Seems to be kind of common in some of the surgical specialties, as well as in some of the behavioral space as well, to kind of model these things out and maybe take some of them to others who may prefer to have a direct contract.
I'm sure over time, as you talk to these types of users that are out there in the areas that you serve, that you end up hearing kind of a common thread of stories that this has been our situation, this is what we've been working on, this type of platform, this is what we're trying to solve. Illuminate that. What is the thing I hear all the time from our new platform users? They're coming because of X.
Yeah, part of it is that there's a lot of overhead to reporting on these programs. And there's a lot of different data feeds that need to be normalized and brought in and processed. And it makes it hard to expand the footprint. So for example, if you want to participate or offer, either way, additional programs, it can be cumbersome to say, well, I've got some fee-for-service business. I've got this one particular program. Now I'm talking about adding another one. And this other program that I have, I would like to expand and do it with more organizations, either on the payer or on the provider side. So that scaling aspect of things is not easy to do. And if you think that the tenet, right, from CMS is to have 90 to 100% of Medicare beneficiaries under value-based programs, and you have commercial programs and employer-sponsored programs moving along behind that, you can have a lot of programs, right?
Right.
And so being able to do that on one platform and have a succinct set of reporting mechanisms is what we believe is a great value that we can provide.
Where do they go to get information about the company to kind of learn about some of these things that you're offering?
Well, hopefully they go to podcasts like the one we're having right here as one, but also to hsblox.com. We have a comprehensive website. We also have some videos on there, short, 1 to 2 minute videos, tell you a little bit about what we do. And then certainly can reach out to us on LinkedIn as well and have a discussion about what use case they might have or how we might be able to help.
Final thoughts before we jump off for the day?
Well, I think my final thought is that things are complex, but they are moving in the industry, and we are seeing increased uptake of value-based programs. We've seen more coming out from CMS just this year, in fact. We're gearing up for LEAD for next year, which will be replacing ACO REACH. And so there's a lot of stuff happening. You often hear that value-based care is not taking the upswing that everybody thought, but sort of a lot of it's happening in the marketplace, and we're happy to help folks get there. And we can help with traditional fee-for-service as well.
If you haven't done so already, make sure that you subscribe to us here at the Kinetic Innovators Podcast. We're pretty much everywhere you're listening to content on all the socials, TikTok, X, LinkedIn, Instagram, Facebook, and also on Spotify podcast as well. And Lynn, I appreciate you taking a few minutes to come over and tell us about what you're doing here in value-based care. Like I say, I think for too awful long, we'll probably be a user of the platform ourselves, coming from my day job over at Aegis Health Services. So thanks for making some time to give us an introduction.
Good to talk to you, CW.
All right. We'll see you all next time. Thanks again for making us a part of your day today. We'll see you.